Attention, I have a wonderful special guest who speaks today. This is our wonderful midwife, Laura Perez. We are so lucky in the Bay Area. We have the best birth workers anywhere. I brag about them all the time. I drag them around wherever I go. I make sure that folks know about them because you might be pregnant yourself next year. Who knows? You have friends and relations and you want them to get competent and lovely care. And I've been honored to know Miss Laura for quite a while now. And we were apprentices together for a hot minute. And she's gone and completed her training, and you can tell the story about yourself and how long you've been doing what you do, but she's quite the midwife. And she is going to talk to us about actually midwifery and its history. So I will turn it over.
Thank you, Jen. You're welcome. I love Samsarah. I want to say that publicly. I love this woman very, very much. She's a very dear friend of her back. So, hi, I'm Laura Perez, and I have these letters after my name. I worked really hard for years and paid the state money to have letters after my name.
Yeah.
I'm a certified professional midwife and a licensed midwife. And what that means basically is that as a CPM, my specialty is home birth or out-of-hospital birth. I have a birth center here in Oakland, Bay Area, midwifery that's going to be training its name soon.
Really?
Like, I don't know the name. It's something like East Bay Community Birth Center. I don't know. So we'll tell you when that happens. And I've had my own midwifery practice for about 3.5 years now. I've been attending births for 17 years in different capacities. And a licensed midwife and LM means that I am sanctioned by the state to legally attend births in the state of California, which has
Is that required?
its upsides and downsides. Well, the law would say if you're attending out-of-hospital births, you need to be an LM. Are there midwives in the state of California that are not LMs that are attending births? Yes. I'm sure there are many. But they don't necessarily brag about it, and they're probably more community midwives, right? And they have a different history in it, but a nice chunk of them are probably immigrants from other countries that attend births in their own communities, basically. And I really want to meet them and follow them around and attend births with them wherever they are. So Samsarah asked me what I could talk about or share today, and I thought I would talk a little bit about what I know about the history of midwives in the United States. There's a lot to say about global midwifery, but I figured it'd be easier just to focus on the U.S. And please chime in if you have more information than I do, and please chime in with questions at any time. So as you know, the United States colonized land. There were a lot of people, I hope you know, there were a lot of people that were here originally, the indigenous and native people of many different nations and tribes that were doing pretty well before the settlers and the colonies came, and they didn't have hospitals and they didn't attend births except within their own communities with each other. And then when the colonization happened and Europeans came, they had some of their own traditional midwives from their own home countries. Of course, the horrible history of chattel slavery in the United States, enslaved people were kidnapped from different African nations and brought here. And something that Miss Divine taught me, I told you I took her grandma's hands class. So she pointed out this thing that I thought totally made sense, is that the people who were kidnapping and abducting and making money off of supposedly buying people were very strategic about who they chose to bring here. They were bringing people here who knew not only some of the men that had muscles and could actually tend to the land, but the women who could actually use their knowledge and skills within the female community, right? The women who knew how to work with herbs, the women who knew how to attend birth, the women who had whatever different crafting skills, right? They were chosen specifically to be here, to be more resource for the community, for the exploitation, for their work and for the people here. So there was some history that was, or traditions that were maintained as best could be in those horrible conditions. So then in the southern part of the United States, you had what different people term either grand midwives or granny midwives, the folks that were potentially enslaved people themselves or descendants of enslaved people that were attending births within their own communities, were doing out-hospital births. And if you know anything about the horrible racist history of the United States, at some point, and I'm talking about the 1900s to 1950s, people who were Black could not even go to a hospital to birth. They were not allowed to go to a hospital to birth, so they had to birth at home within their own communities. And in the western part of the United States, at some point, again, the turn of the century, up until, I'm not exactly sure the timeline, 1930s, 1940s, probably, yeah, right around that time. There was a big influx of Japanese immigrants to the west side of the United States, and many Japanese women were attending births at home with their own communities, but then the word got out that these women were available and doing this thing, and other women who were not Japanese heritage also wanted to not have their babies necessarily in this new hospital setting, because attending births in a hospital is a fairly new occurrence. It started at the turn of the century, mainly more established by the 1940s and 1950s. So a lot of the births that were in California during the turn of the century were attended by these Japanese immigrant midwives. So what happened? Why did all the babies that were being birthed at home and communities that were having their babies at home all of a sudden go to hospitals? Well, first of all, hospitals are a fairly new thing, and doctors are a fairly new thing. At the turn of the century, these people, these groups of men got together and decided, we want to start this new profession. We want to start this thing called a doctor, and we want to propose that we are the brightest and the smartest about anything to do with health and people's bodies. But they actually knew nothing. They knew very little. They were basically making it up as they went along. They created the American Medical Association on their own. They created their own teaching institutions for doctors, and really with the goal of prestige, status, and making money, right?
Let me add that this, what our sister's sharing with us, was very much subsidized by the banking industry at the time.
Yeah.
So there were corporate interests and corporate money fueling the birth of the American Medical Association and everything she's saying.
So part of what happened is they needed to convince people to not do things the old way, to not continue to birth at home, to try this new thing, to be a part of this new institution. And really the idea seemed absurd to a lot of people, to go somewhere to birth your baby in a large room with a lot of other people where who knows who was going to be there and who knows what they were going to do. This was a very brand new idea. So there was, in fact, a systematic campaign to disparage and denounce and any other bad word you can think of, ridicule, smear is a good word, these women that were attending births at home. And the majority of these women were either indigenous women, immigrant women, or either enslaved Black women or descendants of enslaved Black women. And so part of what you hear throughout history is, well, thank goodness, birth is in hospital again because so many babies died back in the day. Like the infant mortality rate was very high. And there were a lot of babies that died back in the day. Now, part of what was happening there, though, is that there were a lot of babies being born to each individual woman back in the day. Because in many communities, women didn't have access to information about how to prevent pregnancy or end a pregnancy. And then women were also, before the agricultural or industrial revolution, women were living off the land and tending the land. You needed to have a lot of babies to help work the land. So that was the food that you grew, was the food that you ate, and if you needed to make more money, you needed to make more food to sell it, right? So what was the real issue in terms of little ones dying was poverty and lack of access to nutritious food, as well as sanitation, right? Those were the actual reasons more babies were dying versus all the babies were dying at the hands of midwives. And unfortunately, that is the mythology that is out there, that birth needed to be moved out of the home and community settings because it was dangerous. These midwives were dangerous. These midwives did not have training. These midwives did not know what they were doing. They were putting the babies all at risk. And the doctors, the knowing doctors and the safe doctors in the hospital provided a better option. And in fact, that's not true. I will go on the record saying that, that's not true. The other thing I want to add to that is that the mythology is that midwives killed babies. I think that's, you could probably find that in the literature somewhere, that midwives were killing babies. So that was in some ways, and maybe not in every way, and depending on what I can find, because I really want to do more research about this, it was double speak as well. On the surface, what that meant was that, again, the midwives were not skilled, the babies were at risk because the midwives didn't know what they were doing, they didn't know how to stop a bleed or get a baby to be resuscitated, whatever the dangers of birth are, that the midwives were not skilled to handle complications, and complications developed and the baby could die because of that. But midwives killed baby was also double speak for the knowledge that actually was held but not talked about, that midwives had the skills to actually terminate pregnancies. Midwives knew how to work with women in terms of their cycles, potentially knowing how to prevent a pregnancy, but also how to work with the herbs in the land, how to do different techniques, different things that people still use today to potentially terminate a pregnancy and terminate it clearly successfully. If a woman did not want to be pregnant, she could turn to her local community healer and midwife and be like, I've already got 5 or 6 or 10. I cannot do another one. Can you please help me? And she would be able to help that mom, right? So there was this undercurrent of these dirty immigrants, these dirty women who didn't, these ignorant women that didn't know what they were doing, were killing babies by attending births, by not having knowledge, and killing babies that actually helping to terminate pregnancies. That's partly of the, I want to say that's part of the history as well, that doesn't get talked about a lot. I personally believe that every woman should have the knowledge to be able to do this on her own. Just, if we're going to go there, just as every woman ideally will have the knowledge to birth her baby on her own accord, with her sisters, with her family, with her chosen community, given all is well, given she's well nourished, well hydrated, and good health in general, it's a pretty straightforward thing the majority of the time. That the skill set to terminate a pregnancy is actually not rocket science. We have the information now in terms of a lot of different things. Meds, herbs, tools that we can make to make this happen safely at home. Talk about safe at-home termination, come on, we're talking about safe home birth, right? So that's something that gets a little lost. I think I consider that a very important part of midwifery history, part of my lineage and my heritage as well. So that campaign was quite successful to disparage all the home birth midwives and the people attending births at home. And they needed, what did they call Dr. DeLee, the famous horrible obstetrician in Chicago, talked about needing material. The material being the poor immigrant women that had no other choice, that didn't have access to an attendant and needed to go someplace to birth their babies safely. And that would be the new and growing county hospitals that were springing up everywhere, because they could get free service there. But what that meant was that a lot of these male obstetricians were experimenting on these women. Experimenting on the drugs that they were using, experimenting on the equipment they were using, and experimenting on what you could and couldn't do to a mama in labor and what you could and couldn't do to a newborn, right? So we have the foundation for the current obstetrical model of care that comes from that time, right? That time, things like twilight sleep, right? Scopolamine was used as it was the new thing because then women wouldn't feel anything. It was a way to help a mama deal with labor. And what many women experienced when they took that drug was they don't quite remember their birth. A lot of women talk about having a memory of hearing a woman screaming bloody murder, and at some point realizing that that screaming was coming from her mouth. That there was a very big distancing and not understanding of what was happening. Her body was pretty much virtually immobilized. And what that meant too was that her baby, so babies naturally assist in the birth process. A mama that is not medicated, that little one is helping. That little one is finding its position. That little one is pushing off with its feet. That little one is using the contraction to help itself be born. So mama's pushing, uterus is pushing, baby is an active part of the process. But when you medicate a mama with a drug like scopolamine, I'm going to say it right, that little one is not, that little is also sedated and cannot help. So then what ended up happening? The use of things like forceps and a vacuum were used to help a baby be born. And DeLee was also, I hate saying his name, but I do want to give him credit for where credit is due, because he was the one that really put forward this idea that birth was an incredibly violent event for the baby and that the babies needed to be saved from their mothers. That's why they needed scopolamine. That's why every woman got an episiotomy, so she was cut in the lower half of her vagina towards her anus. That's why every baby needed help getting out with the vacuums or the forceps, because they could not participate in the process. So then you had all these babies coming out with these bruises on their bodies from these instruments, and there's the initiation of vitamin K in the birth process. Blood bruises and things like that, right? So we're all born with low levels of vitamin K, and so there's concern about a baby doing extra bleeding out from any internal bruises or external things. And so in order to prevent a baby from bleeding out, we have to give a baby vitamin K, and because all these babies were born with horrible injuries, everyone got vitamin K. And we're still following that policy. That is not evidence-based care. Yeah.
And I just wanted to add in terms of other non-evidence-based things, what I had read was the practice of shaving the pubic hair from women before they birth was back to this idea of thinking that the doctors believing that the poor women after the Industrial Revolution coming from the tenements would have lice. And so they would shave them even though there was, it continued to be a practice even though it was initially based in falsehood and then continually still not based in any evidence.
And I think there was the lice thing, but it's also this older belief that that area is just dirty and it needed to be sterilized, that birth needed a sterile area to happen. And in fact, we know now that birth is not a sterile event. There's lots of things that are happening with a woman's body. There's pee, there's food, there's sweat, there's blood, there's amniotic fluid, there's tears, there might be some breast milk. There's lots of fluid happening that's not sterile, and it does not need to be sterile. The baby
needs all those bugs.
That's right. We know about the microbiome.
The microbiome now, right? And all of those germs and all of those things that were been like the Victorian need to purify the whole body.
Right.
It's like all those bugs have a purpose. The baby needs to consume that, needs to get up the baby's nose and in the baby's mouth. The mom needs to kiss her newborn and have all the bugs from its newborn baby, which is a little less than her body, but mom needs to consume the baby. That's why we want to kiss newborns. Why we're all drawn to like their little faces, and especially the mama wants to lick her newborn, like most mammals do, right? Because she's getting stuff from that tasting, and the baby gets stuff from tasting.
That's right. So that, you know, these traditions change with time, thank goodness. We don't do scopolamine anymore. We offer other things like epidurals and Nuvain and fentanyl and Ativan and all kinds of different drugs now that are offered in a hospital setting. I guess I don't really know my time, but what I wanted to stress was about the difference between the obstetrical model of care for women in pregnancy and birth and postpartum and the midwifery model of care, right? So I practice the midwifery model of care. And what that means is that I work with women who are having a healthy pregnancy with little to no complications involved. I work with women that want to have an out-of-hospital birth, that have some degree of trusting their bodies, trusting their own wisdom, trusting their babies, trusting the process that a healthy pregnancy will have a healthy labor and a healthy birth. Not all midwives have this perspective. I also consider myself to be a holistic practitioner. So when I have a client, I'm all about what did you eat today? What did you eat yesterday? What's in your fridge right now? how did you sleep last night? How's your job going? Are you working? Are you looking for work? How's your partner doing? Are they working? Are they looking for work? What's your home situation like? Are you safe there? Do you have running water? Do you have heat okay? Do you need heat? How well are you sleeping? How are you handling stress? Are you hydrated? I'm forever offering women water because most of us are chronically hydrated, pregnant or not. It's really hard to stay hydrated in general. So I do not just look at the woman in her pregnancy, and I'm not just focused on her baby and her blood pressure, because I know that everything else is a factor in her being and in her pregnancy and in her health. I need to ask those questions. I'm all up in her business. I need to be. To really, I think, provide adequate care. Because if there's something stressing her out, if there's something majorly missing in her life, that needs to be addressed. And another really big foundation, I mean, I touched on it, but to say more, for me as a midwife is nutrition. I really do believe that what you eat is incredibly important for your own health and well-being and for that baby. I know Samsarah talks a lot about this too. And what's true is that obstetricians are not trained in nutrition.
At all.
They don't ask the mama necessarily what she's eating. That's not, I think that they believe that that's not important at all, which just boggles my mind that they don't ask about that and that's not a part of their framework, right? So my specialty is the holistic care and natural pregnancy, natural birth, and a postpartum time. I mainly focus when there's a discomfort or a little bit of a problem. My go-to are always herbs and homeopathy first. That's my front line for everything. Now, if there's an infection that we cannot, ideally it's a mild infection that we can try and treat right away and go for and boost the immune system. But if that infection is not mild or gets severe or is not helped by any kind of recommendations I make with herbs and homeopathy, I'm going to go have the mama go to a doctor and get her prescription for her antibiotics. I do not play with that. I want that infection to be cleared. And I will tell her to take her probiotics while she's taking her antibiotics to try and recolonize her gut so that we're not wiping out everything and she's less at risk for a yeast infection or for being get fresh afterwards. So I do work, in conjunction with lots of times.
It's been my experience that very inflamed my reproductive system. So I wanted to ask you about that, if you come across that. So it sounds like it's...
Yeah, I mean, it can. It's not unusual for it to. I think there are some women that can do dairy for days and they're great, but there are more and more women, I think, that are like, it has a not pleasant effect on the body. So, and luckily, there are alternatives.
And especially if we're drinking your common variety milk from the supermarket, if we're drinking organic milk, we're drinking raw milk. There are people who can't tolerate conventional milk, but when they drink raw milk, non-pasteurized milk, they're fine. So everyone's got a different relationship with that, and there are alternatives.
Yeah.
I'd like to know, please, where you got your certificate, your midwife certification, and then also, did you supplement it on your own to learn about the herbs, or was that part of your certification?
So I went to the National Midwifery Institute, and I graduated from there and got my CPM from them. And then the midwives who are licensed midwives need to sit for the North American Registry of Midwives exam and pass that, as well as graduate in order to apply for licensure in the state. So that's a distance learning program, so I do all my academics locally, and I just do all my apprenticeship locally as well. A lot of students have to go out of the country to get their numbers, but I was blessed enough to be able to stay. It took me 9 years. Now I did take a big break and then I had a kid, but I had 4.5 to 5 years of an active apprenticeship. Yeah. So that's that. Did you want to know
The herbs?
Oh, so I had been studying herbs on my own since I was a young person. So that has been something that I've been carrying for many, many years. And then I have taken other classes, I have gone to other workshops and just continue to attend things as much as I can because I feel like I try to stay as humble as I can and know that I will never know everything there is to know, but I will keep trying to absorb and keep trying to be as best a sponge as I can to learn more and more. I don't consider myself an herbalist. I think that's a very dedicated skill set and you really need to know what you're doing. I know I feel like some really basic stuff in herbs that I work with, herbs that I trust, that I will recommend for different things in pregnancy, labor, and beyond. And then the same with homeopathy, self-study and going to different homeopathic workshops. So it's whatever I can get my hands on and learning at the same time.
Thank you.
When you recommend herbs to your clients,
Yep.
do you do that based on what you think the client is already keen on? Or the clients that are coming to you are ones who are interested in that kind of care? Because that's not, it's not part of the training. I wonder how does that work? Are you already dealing with clients who just understand that you're working autonomously as a midwife and that you have training? Is that what they're thinking, or are they? How is it that they're are they looking for that kind of support, herbal support, or they trust you, or is it that they're you know what I mean?
Yes, that's a great question. So I think when they interview me, I tell them this is the kind of midwife that I am. This is how I roll. I love working with herbs and homeopathy. That's my first, and on home remedies. I forgot to mention that. There's lots of home remedies that I love working with. Things you have in your kitchen that you can use for heartburn, for hemorrhoids, for lots of different things that happen in pregnancy. That I love that. And or in your bathroom that you might already have. So I tell them that that's kind of the midwife that I am, and I think that the folks that hire me tend to be like, yeah, either that's what I do too, or I'm interested in that. I've always wanted to learn a little bit more about that, and I've heard that works well. I have every once in a while, I'll have a client that's so not interested in any of that, but still wants to work with me. And then if they're like that, or I'm not sure, I'll always ask them there are herbal treatments for this. Are you interested in trying something like that? And sometimes they're like, no, or they're like, oh, I had a bad experience with herbs. So I'm like, that's fine. We can try something else. So yeah, it really varies.
Because I was thinking about that as a doula as well. If you feel comfortable sharing herbal recipes or remedies and things like that, would that be something that we should feel comfortable sharing with our clients, or we should wait?
It's very important to know the big difference between a midwife and a doula.
Yeah, of course.
And so we'll talk about that. There are limits in how doulas can roll with that. But to make recommendations, diagnose, or treat anything, absolutely not. It's a felony count, you go to jail. Do not pass go. Okay? But we'll talk about how we can.
But pointing people in a direction fast.
Correct.
So let me just say that I wanted to talk a little about who I am and how I work as a midwife in the midwifery model, but talk about the obstetrical model. So I think what a lot of women don't realize when they decide to have a hospital birth, meaning I think a lot of women just don't think about it, that's just the way that the route that ends up they get led to, but they're not making a conscious choice to birth there. I think it looks like a lot of women don't. But so women who are birthing in a hospital setting and they have an obstetrician, I think many do not realize that an obstetrician's specialty is surgery. They are surgeons primarily. And their skill set, and I have to say, God bless the obstetricians. There are women that cannot have vaginal births. There are some women that cannot because of a lot of different reasons. And that surgical birth is recommended in the only way that baby's going to be born. So God bless obstetricians for that they exist and that they're doing that. Yeah.
Can you give us maybe one or two examples of your experience where it had to be an OB delivery versus a natural?
You mean a surgical birth?
Yeah.
So something like complete placenta previa. Right, so the placenta is in the way of this, is right behind the cervix. So when the cervix opens up, there's only placenta. The baby cannot go through the placenta unless it's a very special baby that has magical powers. That cannot happen. Literally, there's a barrier to the vaginal birth. So that's placenta previa. With previous, it's before the cervix, right? It's part of the way out. There are some very few rare women that have pelvic abnormalities. They literally, their bones cannot open up enough to let a little one pass through. Luckily, that's incredibly rare, but it can happen, and it does happen. Rickets used to be a thing. It's not a thing so much, but I hear it's coming back into favor, unfortunately, because women are having decreased levels of vitamin D and other things in their diet, right? I'm trying to think. Like a cord prolapse. Cord prolapse. So again, thankfully, very, very rare condition where before the baby's body comes out, the umbilical cord is coming out of the body. Now, the umbilical cord is the baby's lifeline, right? It's inside the bag of water with the baby. The cord is attached to it. It's part of the placenta. And once the cord is out of the body and exposed to air, the magic happens, right? Where there's a substance inside the cord called Wharton's jelly, and its job is to protect those two arteries and one vein in that cord. Keep it malleable, keep it from being squished, because that's the baby's lifeline. But once the cord is exposed to air, the Wharton's jelly hardens. And it's assuming it's done its job. It's waiting to make the transition from intrauterine life to extrauterine life. So if that happens, that baby's oxygen supply is cut off. And then that baby is at risk of dying, right? So if it's actually a cord prolapse, the cord is coming out, you gotta cut the baby out. There's no way you can have a vaginal. You can try, but you really put the baby at risk. The baby needs to be born vaginally. There's like really, really rare conditions like those things where a surgical birth is needed. What was I gonna say? So, yeah, sorry.
We're gonna finish it.
Yeah, so I just want to say that obstetricians are surgeons, and not only that, their skill set is to look for problems. They are always looking for a problem. And I think somebody's got to look for the problems, that's great. Because if there's a problem, we should know about it. But that obstetricians really, I think their skill set should be with quote unquote high risk pregnancies. Mamas that really need special attention in their pregnancies. Mamas that have serious hypertension, mamas that are gestationally diabetic, mamas that have other major conditions with their body, central nervous duct damage, and have regular seizures. There's lots of different conditions where it's like it wouldn't be safe necessarily to proceed with an out-of-hospital birth because there's stuff that could go down that's all bad for the mama and the baby. So that's, that's how I view obstetricians, and again, God bless them for the work that they do. Unfortunately, in the United States, what we've done is we've made the obstetricians the people who provide all the births, who attend, and some nurse midwives, who attend all the births, regardless of whether or not they're healthy, normal, low risk, high risk, whatever. And it's a bit of a setup, because if you have someone attending a birth that is straightforward and they're looking for problems, they're gonna find them. That's what they do. That's their job.
And the interventions make problems.
That's right.
So they have their self-fulfilling prophecy that there's going to be problems because you're giving a perfectly healthy person all of these medications that each and every one hampers the birth process in one way, shape, or form. Some women are able to get through it and be kind of all right, and some women have a devastating effect, and some babies have a devastating effect, response to these drugs. So that every time there is a complication, they're like, well, see, we knew, and it's a good thing we're here. So they have this crazy little mind trip going on there that they've been able to feed women because women fear home birth and they fear their bodies, and I have to go to the hospital to be safe. They're going to the hospital because they really believe it's the safest place to be.
And let me say the last thing I'll say is weird. No, maybe it's not the last thing I'll say. The thing that kind of drives me really batty and mad. I spent way too much time on Facebook, just way too much time on Facebook, and on these different groups and around birth. And what I see over and over again, and what I hear in the wide world too, is mamas that had very challenging births that ended up having a C-section and will say, if I was not in the hospital, my baby would have died. I needed that C-section. Thank God that that's where I was, because my baby would not have made it, and maybe I wouldn't have made it. So it was such a good thing that I was in the hospital. And I did want to reply. I could not reply. And basically what I said was you are comparing apples and oranges. If you did not have a complicated pregnancy, if it was a normal healthy pregnancy and you were at home, you would have not have gotten that epidural. Your baby would not have those D cells. Your blood pressure potentially would not have gone up. It would not have been an emergency situation where your baby had to be cut out of you. You do not know. You will never know because you didn't choose to birth out of hospital. So it's possible that it would have been straightforward. But I don't blame women because I feel like that's the story they need to tell themselves, that they made the right choice, that the doctor saved the baby. Yeah, that's true too. You made the right choice. The doctor saved my baby. I would have died. My baby would have died. Thank God I was here. And I just don't think you can ever say that in terms of that. You cannot say that as a blanket statement because we don't know and we won't.
Here's another thing that drives me crazy since we're talking about that. And I had to get off the mommies groups on Facebook because it's just too tragic hearing what these ladies are saying to each other. But there's the myth of the emergency C-section.
Yeah.
I had an emergency C-section. So let me tell you right now what an emergency C-section actually is in the hospital, okay? Yeah, exactly. Yeah, you know, and also the emergency C-section should be this. The lights are all flashing on the monitor. It's calling a code.
Yeah.
They do not talk to you. They do not give you 5 minutes to talk to your doula. Screw the doula. Don't have time for daddy to put the little booties on, to wait for a half hour for the operating room to become available, and then wheel the mama in, and have time to take pictures and do all the stuff. That's not an emergent scenario. But that is the majority of C-sections that happen. So there's a whole bunch of people who are talking about an emergency C-section they didn't have.
And a routine.
Or it could have been, they didn't want to wait.
Failure to wait.
There's a C-section where it's like, we need to get the baby out now, but there's not a room available, so we have to wait. Do you know what I'm saying? Like, that does happen. But I hear what you're saying. There's emergency probably is like woman under general anesthesia. We got to get the baby out.
They slap a mask on.
You gotta get the baby out.
They kick other people out of the operating room because it's an emergency surgery coming in.
Yeah.
That's what it really looks like. Yeah. So what happens in the hospital is this whole other thing. It's a failure to wait. It's doctor that's not knowing how to manage doctor's not knowing the position the baby's in and not helping the mom get into positions that would help birth be more optimal. People not having doulas to give them that same love and advice and how to help the little wiggly baby getting out. It is the day of the week. It is whether there's a strike at the hospital. I had a section called on a client who was in the middle of pushing because at Alta-Face the nurses went on strike, but just while she was pushing.
Wow.
And the strike was called, the nurses all left the room, the new nurses came in, followed by a doctor saying, we're going to be calling this a section. And she's like, what? The baby was in the birth canal. The baby was coming out. They were just like, we're done. So.
Did that end up in the C-section?
I'm sorry?
Did that end in the C-section?
It was a C-section call. The C-section happened. Broke the client's heart. And so, yeah, there's lots of reasons why C-sections happen in hospitals that have nothing to do with emergencies.
Or medical necessity.
Yeah. Where are we for time?
I have to stop, but I want to see if there's any other questions.
Yes.
I have a question. So I was previously working in internal medicine, and there was a young woman. I don't know all the details of her case, but pretty much she had a natural birth, and her baby was either between 8 to 10 pounds. But after the birth, she had gotten birth. There was a gap or a gate between her bones, after, and I don't know the outcome if in time it
Her
healed.
pelvis.
Yeah, her pelvic bones wouldn't go back to or go back where they were initially, and she kept coming back to the doctor upset with him, why didn't you do something? Maybe why didn't I have a C-section? What's happening to me? I don't know. Have you ever seen cases like that postpartum or post-birth?
This pelvis opens up in the name of the.
I don't think I personally have. I think I may have heard other midwives who had situations like that.
And then,
You guys are probably gonna get to this. I'm shadowing a doula / midwife who's got 600 babies already. I've heard from different people 2 different answers. In this work, is there insurance
Meaning, can you?
for midwives,
for doulas as well
so
as?
let's leave it, we're talking to a midwife right now, so the question's for a midwife about midwifery.
With midwifery, is there insurance?
So generally speaking, what most of my clients do, they pay me out of pocket, and if they have a PPO that has out-of-network coverage, it's possible that they can get reimbursed. Did you have a question?
Just for a licensed midwife in California.
Say that again?
For a licensed midwife in California, that what Sister just said is applies.
And licensed midwife in the state of California can now get reimbursement from Medi-Cal, which is kind of exciting, but Medi-Cal pays very, very. I mean, they pay, Medi-Cal doesn't even pay the low end of my sliding scale, and I cannot ask for any other additional money on top of what Medi-Cal would pay me, because that would be a fraud, which is ridiculous.
What's
So
the-
Medi-Cal pays less than $2,000 or something.
We had a hand up here.
I thought that what she was asking you was like if you need to be insured.
Like malpractice insurance?
Yeah, malpractice insurance.
Was that the question?
No, I think she was asking something different, but I was thinking that part. Do you have to have malpractice insurance?
You don't have to have it, but you have to disclose to your clients if you have it. I don't have it. Did you have it?
What's the average birth cost for the clients? Like, if you really were to factor in how much your time, your tools, what's the actual
If I was a business savvy midwife, I'd know that answer like that, and I do not know the answer.
Would you say it's over 5,000 though?
You probably know better than I do. I don't.
I just know what they charge.
Who's that?
Who's
What
they?
is
Hospital?
Medi-Cal, what is Medi-Cal paying?
I know what non-midwife coverage, I know some for 75.
Oh, yeah, absolutely. I mean, but you're not asking what you charge, it's like how much does it cost?
Like,
No.
actually, as a business perspective, like, you were to calculate your time, your tools.
Oh, that's,
I have no idea. I really
how
don't.
are you going about 24 hours for 40 weeks plus 6 weeks postpartum?
Well, for example,
How do you, 24 hours
That's
Yeah.
real, that's real.
for 40 weeks, if you start with your client early, plus 6 weeks postpartum to your last 6 weeks.
So that's just being on call, that's not how many visits you
That's-
have with them,
yeah,
that's
I'm
not
just
how long
saying
you attend the birth with them, that's not any additional consults you do with them, that's not any, paying the other assistant midwife that comes to the
Yeah.
birth with you, that's not being off call and then paying another midwife to be on call for you to do any other prenatal or postpartum visits you might need. There is a lot involved in that, for sure.
Walk away.
So I'm asking seriously, because like, I'm thinking like, for example, I delivered our first kid, and the cost out of pocket for me was 20% of the care was about, I think, $5,000. Would you say that Medi-Cal is paying you anywhere near what it actually costs?
Medical plan is less than 2,000.
That's what I was trying to understand, like, really, like, how much are you being paid?
I think I heard maybe up to 24, but you have to like bill like every little thing, and they don't necessarily reimburse you for everything.
And this is why when a pregnant woman's birthing in the hospital, she's likely to have way more stuff done to her.
Right.
Because they're trying to bill Medi-Cal. So you're likely to have the whole kitchen sink thrown at you.
Yeah.
Because they're trying to make some money because they pay so.
Right, that's right, that's right.
I have kids, and I'm gonna date on, this is an Medi-Cal now pays midwives. And do you know when that law passed or what date around?
It started this January, yeah.
So for the sake of time, I want to open up space for someone who has not asked any kind of questions yet.
I just had a statement about the C-section, how they try to call it emergency. A sister of mine, she just had her child on the 17th, and the umbilical cord was wrapped around the baby's neck, but she still wanted to have a natural birth. And so the thing is that a friend of mine who was a part of the delivery team, she was like, well, no, we're going to get this baby out. But while they were still trying to, have her push in between the contractions, in the background, they were like setting up for the C-section. So like they were just like, okay, the heart rate's dropping in between contractions. Let's not even try to get this done. But luckily my friend was there she, you know, she had, you know, was like, no, we're gonna do this, and they got the baby out in 4 pushes.
Wow.
And you know, that was that. But the baby, the umbilical cord was wrapped around her neck twice and around her body. So it was just.
You know, again, that is the thing that they use to scare people. I mean, it depends on a lot of things, how long the cord is, how tight almost all babies have the cord wrapped around them, wrapped around their bodies, wrapped around their necks. I mean, I've seen that with the little one that was born with all of this is covered up by a umbilical cord. But it was a heck of a long cord. So, and it was a home birth. And unwrapped the little cutie and no big deal. No bruising on the neck.
It's very
no,
rare
it's-
that the cord is an issue, but
Yeah.
the hospital acts like it's the end of the world, and it's very rare that it's tight enough for anything to do damage.
I have a question. Would you say your relationship and interaction with doulas differs than that of like a obstetrician?
Yeah, I don't think
Yes,
obstetricians
she
have,
loves
I
and
don't think
respects
obstetricians have relationships with doulas, really. I mean, they might interact with them in a hospital setting, but mainly I see obstetricians ignore doulas in a hospital setting. Whereas I, especially for my first time mamas, I want them to have a doula. Birth center birth, home birth, it makes a really big difference to them. And the doula is the person that I kind of count on to be there with the mama doing every contraction when it's active or when it's hard. I am doing my assessments, right? So I'm taking her vitals, I'm listening to the baby, I'm watching her, but I'm not necessarily with her during every contraction. If she wants me to be, I can try and hang, but the thing is, my job, when I need to be at the peak of my best and doing what I need to do is when that baby is born. So if I'm hanging out with her hours and hours and hours and hours and she's getting tired, I'm getting tired, that compromises me to not be at my best when that baby is born. So I definitely need, if it's a long, long labor, I need to step out and sleep or tag out or have another midwife spell me because if the baby has trouble getting out, I have to get the baby out. If the baby needs to be resuscitated, I'm responsible. If the mama starts to bleed, I have to stop that bleed. I just need to be on it once that baby is born. And not that I don't want to be there with a mama when she's laboring hard, and I do spend a lot of time with my mamas when they're laboring hard, but I have to be mindful about what I do. So that's why I lean on the doulas. And also, I give homeopathy and homeopathics regularly in labor, and that's why I'll tell the doula, here, give a mama 1 or 2 pellets every 15 minutes or every half hour of this, and she can do that while I'm doing whatever else I need to be doing.
Yeah, so I've heard women say, well, I have a midwife, so I don't need a doula, because, you know, they practice, you know, the whole woman wellness.
Yeah.
And that's, you know, if they were going through a birth in the hospital with an obstetrician, they would kind of lack that personal touch, and so they would feel they need a doula, but if they use a midwife, like, well, I don't really need one, because a midwife got me covered. But you're saying you still need the doula present
Again, a
for.
first-time mama who really has no clue of what's up, I recommend that. Now, a second, third time, fourth time mama knows what's up, she may or may not need a doula. Doula also might not make it on time because they birth faster, so there's that.
Mhm.
Yeah.
It's also about respecting that these are 2 different professions. And some midwives don't have the same value as doulas as other midwives. So midwife law is very respectful of doulas and understands that there's just the gifts that a doula can give her client that she can't. And even your apprentice, like even if most midwives work with a partner or an apprentice, but the apprentice is focused on learning to be a midwife. When I was the apprentice, doing the hands-on care of a doula was very challenging to do both. You know, because you're looking at the mom in a different kind of a way. Yes, you do provide comfort and care, but there's a different way of tracking. We'll talk about that. This is about well-being doulas. But how we're tracking the client is very different than the way the midwife is. And there are ways that we can work together. There's things the midwife will see that I don't see, and vice versa. And so it's more collegial, like more respectful of each other. And I wish that I could work that way with a doctor. I wish I could call a doctor and say, hey, Dr. So-and-so, I'm the doula for your client. Let's go out to tea and discuss the client. They would laugh hysterically.
Right.
They would be hysterically laughing as I hung up the phone. But a midwife is, oh yeah, and at the very least we'll talk. A midwife might be too busy to go have tea. She's like, oh, hi, I'm happy to meet you. And what do you think? And how do you feel? Have a good conversation. So we go in and have a birth team meeting, or midwives have a birth team meeting. So 38, 37 weeks, we'll all get together, grandma's gonna be there, midwife's gonna be there, doula's gonna be there, we'll all talk about what is the client's deep vision for her birth. How does she see us all supporting her beautiful passage? What does her partner need? What does grandma need? I love grandmas. Taking care of them, because they're crazy people.
They really are.
Oh my
They're-
God!
They're the loudest at the birth. I love them. They have a grandma's looking at the baby kind of going, oh Lord! Oh Jesus! Making all the like noises from watching their daughter push the baby.
We gotta love them up because most grandmas are birth abuse survivors. And they have not had anyone to support or be there for them. So they're holding their, even when they're trying to be supportive to their daughters or their sons, they're still like, their birth is playing in their head.
Yeah.
And unless they have had someone take them to the side, I always make sure to touch grandmas and talk to them, try to talk to them ahead of time, meet them before the birth if I can, and have them tell the birth story, because all of us who've had babies, it's the most important, vital story of our lives, and we don't get to talk about it, and we don't get to tell anybody. There are people who've been sitting for 50 years with birth trauma, and it's affected their whole motherhood.
Or they've talked about it and they've not been heard.
Yeah.
Like the parts that are important to hear about where they were either disrespected,
Yeah.
or where what they wanted didn't happen, or where there was a moment of joy that was ignored. I mean, there's so much. It's about, I think, the listening and hearing those gems of where that mama can cry, or where that mama can be proud, where she can be triumphant, or where she needs to fall apart because it wasn't what she wanted, or it was terrifying, or whatever
Or
the
some
story
flip
is.
comment from somebody,
Yeah,
because women,
yeah,
this is another thing that just works my nerves, everybody needs to watch their mouths with a woman who just pushed the baby out, or pregnant people. It is so easy for one word to cut through her psyche and damage it forever until she can get to a shaman and have a soul retrieval. And that's for real. At a woman's bedside, it's not the time to joke, not the time to be sarcastic, not the time to be cute. It's not about you.
Right.
I mean, I just want to smack people, that let's be in that quiet space and let's say what she needs to have said. Let's find out what she needs. You might have thought it was the greatest birth ever, and she's there devastated. She's there feeling that she failed. Find out what she needs so we can prevent this cycle of birth trauma, so mamas really can be there for their daughters. It's so sad that so many of my clients don't even want their mother there.
Oh, yeah.
That's sad.
Just quickly on the role of grandmas. Growing up, when my older sister would have kids, my mom, we were all in the same city, my mom would essentially be there when the baby was born, and then kind of move in with my sister for no less than 3 weeks, and still go to work and stuff, but she was there to take care of the other kids, cook, clean, wake up with baby. She thought nothing of it. This is what you're supposed to do as a grandma. You're supposed to go and clean for your daughter, feed the baby in the middle of the night.
Very
And so that
accurate.
was just a very automatic thing. And so when I told her about this training, she was like, oh, it sounded really familiar. She didn't know the name, what doula meant. And I was like, I think it's what you already were doing.
Exactly.
Not to minimize this training or anything like that, but it was just what she just naturally, she's like, well, this is what my kid needs, is somebody to support her. And she just essentially would move in after each baby.
And in some African cultures, the mom, once she's pregnant, leaves her home, goes to her mother-in-law or her mother's house and stays there for the majority of the pregnancy. And the male partner comes to visit. And then after a while, after the baby is born and named, then they all go home. Yeah, very different world. We need more of that. We need a lot more of that, So, thank you.
Thank you.
Quick question.
Quick.
Yes, so what is your perspective on the certified nurse midwives versus like the certified professional midwives, so the ones that work in the hospital practices? Do you have any?
So certified nurse midwives are trained first as nurses, and then they get the midwifery specialty on top of that. They're trained to do birth in a hospital setting. There are a small handful of nurse midwives that attend birth out of hospital or that have birth centers. They learn birth differently.
Then,
I mean, again, the nurse is first.
right.
So I'm not a nurse, and I do place IVs, but I don't like placing them. I really do feel like if you need an IV, maybe we should go to the hospital. And there's a lot of home midwives that like have their IVs, and it's the thing to do to prevent going to the hospital. If the mom was like dehydrated or whatever and exhausted, so you give an IV and they don't have to go to the hospital, and that's fine. That's one way to do it. It's really hard. I really try to focus on like what were the old ways? The old ways we didn't do IVs, and it's hard because I think that there are some women that really want that at all costs, not going to the hospital. So that means I need an IV. Give me an IV. I struggle with that.
You need to look at in this country, this is the only country that has nurse midwives.
Yeah.
Everywhere else you are a nurse or a midwife. You want to be a midwife, you go to midwifery college and you become a midwife. Only in this country do we have this thing, and I get very radical about it, because if you train somebody else first in the fear-based medical model and give them a smidgen of midwifery, where do you think they're going to go when the poop hits the fan? So I respect indigenous medicine as much as I respect allopathic medicine when it's used appropriately, and actually have more faith in natural medicine and holistic medicine than allopathic medicine. I think allopathic medicine is actually needed less than 1% of the time, most of the time. It's about prevention and lifestyle first and foremost, and then herbs and homeopathy and all that stuff. So if your training is top heavy in fear-based information, the little smidgen of midwifery, it does affect how you do your work. Also, until they change it, midwives in the hospital are not independent practitioners, meaning they don't call all the shots for their client. A doctor oversees them and can counteract what they do. At home, the midwife is with her ancestors, her knowledge, her two hands, her heart, and her courage. A very different practitioner. Speaking to different voices. So we're gonna stop now. I know we've got lots of questions. And usually I don't even have this the first night. I usually teach you some stuff first, and then, but this is when Midwife Flower and our beautiful midwife over there we're ready to speak. You're happy?
So,
Yes.